And now to introduce our first keynote speaker for the forum, I'm delighted to introduce my friend and colleague who is President and Chief Executive of the Institute for Healthcare Improvement, Maureen Bisognano.
Good morning, everybody, and welcome to the forum. I am so excited to have this many people all together working on the kinds of challenges that we just heard about. Again, one of the largest forum we've ever had with the people from all over the world, and I do really appreciate how much we have to learn and teach together. So a special thanks to BMJ and to all the staff from IHI who are here and those back in Boston. But like Fiona, I wanted to start by remembering the tragedy that happened in Boston this week. We've been away from home, but following very closely the news there. And I'm so gratified by looking at the response of the healthcare clinicians, the first responders. And as I watched videos and looked at pictures about what was happening there in Boston, it struck me that we were looking there at what I'm going to talk about here this morning, which is reliability, resilience, and empathy. And we saw in the first responders reliability in that they had set up tents to take care of dehydration and hypothermia, and immediately were able to transform from taking care of the normal marathon kind of problems to taking care of trauma like they had never seen before in many cases. So they were reliable and they were resilient. They were able to turn their attention from normal care to emergency care and do it in a perfectly easy way. The thing I was so struck with, though, was empathy. And I was reading stories about doctors and nurses who were, on the one hand, taking care of patients who were dehydrated and then seeing this horrible trauma, and they would turn and cry and then turn back and take care of patients. And it was just an amazing thing to see that. And that's, in essence, I think what we're here to talk about this morning. How do we create reliability? How do we then create resilience when something goes wrong? And how do we build in empathy? I pulled up this Chinese proverb that I thought was helpful in what I wanted to talk to you about this morning, which is, I hear and I forget. I see and I remember. I do and I understand. So I'm going to, this morning, not tell you what to do, but teach you how to see in a different way. Teach you how to see in a different way and give you homework to do so that when you leave here this morning, I'm giving you some homework to activate you, as Robert Francis said, to move from the hearing to the seeing to the doing, and that's where we need to end up today. Now, why do I talk about seeing? It's because we're so busy right now that I think in some ways we're not seeing the problems that we've got here in our busy lives. The schedules are crazy, we're not sleeping enough, and we've got this pathological addiction to devices. I mean, I can see all these lights flashing in the room, but I'm sure that you have, like I have, in the past couple of days, see someone walk into a pole as they're walking down the street on their telephones. I mean, we've gotten so focused on the technology that I think in a lot of ways we're not seeing what we really need to see. So I'm going to talk about some challenges for seeing today. First of all, how many of you are leaders in the room? Quite a lot of leaders. I'm going to talk to you about a new way to see across the continuum, a new way to see the journey of the patient as a whole, a new way to think about big data and how do we begin to not only see what's in front of us today, but to see into the future, because that's the job of leadership, I believe, today. It's to look across the continuum, and it's to look to the future. I'm also going to talk about seeing all of the assets that patients and families bring. I think in some ways we're still stuck in a hierarchy of caring for patients instead of caring with patients, and I'm delighted to see how many young people, students, are here today, because I think we're already seeing a different generation of caring with as opposed to caring for. And then I want to help you to see outside the walls. It used to be that when you went into work in the morning, you were an ICU nurse or you were doing surgery in an operating room. You had your place, you had your procedures, you had your interactions, but it was so well defined. And the challenges of healthcare today are global. They're different. They're bigger. And I don't believe today that we can solve the challenges we face, that we can get to the IHI triple aim of improving the health of a population, improving the experience of care, and reducing cost per capita without a whole new way of seeing. So I want to start with the leaders, and I'm going to tell you a story about Boeing. I'm going to be asking you to think about healthcare as I tell you a story about an airline. So some years ago, Boeing and McDonnell Douglas merged, two very different cultures. Boeing has a culture of innovation and big dreams and big vision, and McDonnell Douglas has a different culture. They're very risk averse and they're very lean and they're frugal. So don't we see this in healthcare today, that we've got mergers of cultures? And I think what happened here was that they came together with a huge dream in mind. They wanted to create the Dreamliner, and it was going to break through in aviation history. I still do believe that I will fly on a Dreamliner in the not too distant future, and it will be a totally new experience. But what happened along the way was that the leaders, I think, were attending to the business of the merger and perhaps not looking at the challenges of the culture. So what happened was, early on, problems happened. In order to be lean, what they did was they decided to outsource and outsupply. They created what they called strategic partnerships and bought lots of their materials where they hadn't done this before. So again, the job of seeing as a leader means you have to go up to the balcony, and it's not am I buying the best supplies, but is the assembly process working? And that's what we face in healthcare, I think. We've got mergers and changes in structure. We've got hospitals now looking at partnerships with primary care. Do the electronic records work well together from primary care to specialist office to hospital? And so I think we've got an assembly problem that says we need to get up onto the 30,000-foot view and make sure that all the pieces work together. You can see here the CEO said, I think there were places where we went too far. Clearly, we made some poor judgment calls in terms of what people's capabilities were. It's really putting it all together, I think, the leadership challenge. Pretty early on in their life cycle, they had what they called teething problems. That was little signs and symptoms that were popping up, that were alerts that perhaps things weren't going as well as they wanted to. And they called them teething problems. But pretty soon what happened was, just January 7th of this year, all of the Dreamliners were grounded until they were able to come together and take another look at the assembly process. Now, I do believe the CEO's quote here. We have the innovator's advantage, even though we stumbled while getting here. And what I want is for us to learn a lesson from this, to say that in healthcare, we need to be able to see the teething problems. We need to be incredibly alert to what's happening on the front line, so that as organizations change, as mergers happen, as structures emerge, as electronic records come in, that we in healthcare are learning those lessons, and that we're able to get leadership teams to step up onto the 30,000-foot balcony and say, is the journey working okay from the patient's point of view all the way from beginning to end? Do we have the data that we need, and are we looking to predict? An example from healthcare. I don't know how many of you have visited North Shore Long Island Jewish Medical Center, but this is one of the largest systems in New York State. And if you go and visit there, and I hope you do get to come to both visit IHI in Boston and North Shore, there's a place that is kind of this 30,000 view. It's a place I've not seen anywhere else in a hospital, but it's what's called the command center. And when you walk into this room, you see big screens up on the wall, and you see people sitting there, and they're looking at the screens. They're looking at the data. They're looking at the journey. And there's on one wall a big map of Long Island and Manhattan. And what it shows there is all of, right down to the postal code, the zip code, it shows all of the dynamics of what's happening in that area. It shows, as an example, they know from the demographic data that in a particular neighborhood there's a high concentration of elderly people who have Asian descent. And they typically get up at 5 or 6 in the morning, the elderly people, and they go out and do Tai Chi. And so they're watching, they know what's happening in this neighborhood typically. And on the other map, they're watching the weather. So if the weather is coming in and there's ice or snow, what will happen is they will send an ambulance to that neighborhood before the 911 call comes in. They're predicting that a call may come in, and they're putting the ambulance in the neighborhood. They've got all these ambulances throughout the area, managing tens of thousands of patients each year, and they're doing it predicting where the call is going to come in. They're watching weather on one side, they know the neighborhood demographics, they know the history of the times of ambulance calls, and they know events that are happening, like we've got a parade or we've got Occupy Wall Street. You know, they're very aware of everything that's happening and putting this all together so that they predict patient need and respond to it even before the 911 call comes in. They even have a wall that has the number of cases of swine flu in Australia, because that's going to predict how many vaccinations of swine flu they need to buy in New York for the coming season. So all the data is there. They've decided to use it to predict and manage care in a very proactive way from the 30,000-foot point of view. So what I would ask you to do for your homework is to think about high reliability processes, to think, have you used it? And here at the forum this week, there are so many wonderful sessions on high reliability. There are so many sessions that will help you to build the skills and get just the right processes in place. But you'll notice that even with highly reliable processes, sometimes they'll fail. And you need to build in resilience at an executive level. You need to be able to surface and see the potential defects. You need to hear when there's a problem on the front line. And that's the leader's job of the future, I think, is taking a look over the whole and making sure that you've got robust and effective processes for the front line. We can't let doctors and nurses anymore be surprised at things, be trying to manage failures in supplies or failures in flow. We can predict that now, and I think that is the new job of leaders. So your homework for this piece is go home and navigate a journey. See with new eyes. What is it like before a patient comes into a hospital? What is it like during the entire journey? And who and how are you sending those patients home? Are they going home to fully supported families, or are they going home by themselves? And when you see that journey once or twice or 3 times, it'll give you the kind of new vision that you need, I think, in order to manage from that 30,000-point view. And ask yourself the question, are all the pieces fitting together? Do people have the knowledge from the primary care site to the specialist office? Does the post-op report get back to primary care? Are all the pieces fitting? That's the job of leadership. At the middle level, I want to take you on a journey and tell you a story about a tale of 2 patients, with apologies to Mr. Dickens. But here we've got a middle process, a middle of the organization process. And I want to tell you about a story that I had, a day I had about a year ago now, when I met these 2 patients in the same day and had 2 different experiences, because, again, it's a new way to see. The first patient is Jess. Jess is the daughter of one of my fellows, and she is a joy, a tremendous little kid who brings happiness and smiles to every person that she meets. About a year ago, Jess had an intracranial bleed and had some very difficult and challenging surgery. And when I went to visit Jess in the morning one day, I was with Jess's mother and father, her older brother, and we were sitting by her bedside. And watching what happened was pretty remarkable. There was a whiteboard in her room, And the nurse would come in and write her name on the whiteboard so that everybody in the family knew who was taking care of Jess on that shift. There was a sense when I went to visit, as an example, I said to Jess, I said to the nurse, what time are visiting hours, or are there visiting hours? And she said, we don't have visitors here. She said, everybody's welcome. And it was such an amazing feeling for me to feel that not only her family, but everybody who loved her family was there to support them. It was quite wonderful. The rounds were amazing. The surgeon came in, the nurse came in, and standing at her bedside, they focused not on themselves, they focused on Jess. And I remember the surgeon saying to her, Jess, what do you think? And she pointed to her head and she was saying she was having pain. So he turned to the nurse and said, when did Jess have pain medication? And she said, 6 a.m. And so they wrote on the whiteboard, it'll be about 10 a.m. and maybe 2 p.m. But they started to plan the day around Jess's goals, which were to be comfortable. The surgeon said, we want you to get up and walk today. So if you have pain medication at 10, maybe we'll bring you to the playroom at 10:30. And if you do well there, then at 2:30 we'll walk you to the end of the hallway and back. They said, we want you to start to eat. And so they asked Jess, what's your favorite food? And I remember it was Fruit Loops. And there was a big bowl of Fruit Loops on her tray for lunch. And then Chris and his wife could plan out their days. They were saying, okay, I'll go home and take a nap and take a shower here. I'll do the same here. So that everybody's day was planned. First around Jess, then around her family, and then around the clinical procedures that were necessary. And I felt so proud of the healthcare system. I felt so amazed that we had made such progress to move to real patient-centered goals, multidisciplinary rounds, team spirit, everybody on the same page, and certainly complete patient and family engagement. This is Jess now. She's amazing. As a matter of fact, I was going to bring a little video that she just sent along where she was doing that gangman dance, whatever. She sent me a video where she had just done the whole gangman, whatever. I don't know, but it's breathtaking to watch her completely take over the stage and do a whole dance. But I was so proud of the healthcare system. I then went to visit my brother-in-law, Bill, at a different hospital just a few miles away the same afternoon. Bill's experience was very different. Bill had some tremendous surgical problems, colostomy, urostomy, and had a 4-hour journey through the operating room. When we, the family, wanted to go visit him, they said, well, we think you should wait another 2 hours. And we said, why do we need to wait 2 hours? And they said, well, sometimes things are busy up there. That's not a reason to keep a family and a patient apart. Sometimes things are busy. They didn't even know if they were. When we finally got in to visit him, the person on the other side of the desk said, who let them in? It was very clearly not a family and patient-centered place. And I sat next to Bill's bedside, a double room, which I don't believe should exist anymore in healthcare. And the patient in the next bed leaned over to Bill and he said, hey, Bill, do you know what MRSA is? Because the guy who was in that bed yesterday had MRSA. And then he went on to explain about this infection that man had had and totally devastated Bill. The first physician who walked into the room to take care of Bill said, I think you should take a lot of pain medication, because if you take a lot of pain medication, then you can get up and walk and you'll be able to go home more quickly. Within 5 minutes, another physician came in and said, if I were you, I wouldn't take any pain medication, because if you do, your colostomy won't work as well and you're not going to get home. So Bill turned to me and he said, who do I believe? The next physician came in and said, if you eat a lot, you'll be able to get home sooner. And the next nurse came in and said, you're NPO, and took the tray away. All day long, never multidisciplinary rounds, never patient goals. It was always each individual professional coming in and doing their bit on their body part. And Bill was left to try and figure it out for himself. It was a devastating experience to see the lack of teamness. There was no whiteboard. There were no multidisciplinary rounds. There were repeated individuals, each one doing what they felt like their job was, but no connections. Bill was left to connect. So I guess what I'm talking about here on the patient level is learning to see at a different level. As Susan Edgman-Levitan at Mass General would say, it's not what's the matter medicine. It's what matters to you. It's not what's the matter, I have a sore thumb or I have a high cholesterol level, and then us responding to the symptom. It's what matters to you and figuring out Jess wants Fruit Loops. And when we start to get the patient and the family engaged, it totally changes the power equation, and we're seeing much better clinical outcomes. So your homework for this piece is sit in on a patient rounds. Sit in your hospital on a patient rounds. Are you seeing Jess rounds or are you seeing Bill rounds? And that's your job, is to sit and see. When you see it, you're going to find that there are very different experiences in different units, and your job as leaders, your job as clinicians, is to move from what's the matter medicine to what matters to you. Another airplane story for you. So Jetblue is a new startup airline that came to the United States in 1999. And I loved their mission. Their mission is to put humanity back in air travel. I was like blown away when I read that mission. They said their mission is to put humanity back into air travel, and they want to do it by providing excellent service and at a low cost. It sounds like the IHI triple aim to me, as near as I can tell. But JetBlue had a problem. On Valentine's Day in 2007, there was a huge storm that rolled into the Northeast. And JetBlue, being the empathetic airline that it was, they didn't want to cancel flights because they knew how much the travel meant. So they decided to try and fly. And it was a rainstorm, an ice storm that was going to turn to rain. So they kept loading up the flights in New York City. And as you might know, the airlines can land in ice, but they can't take off in ice. So the planes kept landing, and JetBlue kept loading up the passengers, but they couldn't take off. And in many cases, passengers ended up sitting in a plane on the tarmac for 6 hours. Well, it was devastating to JetBlue. It was a huge problem. It devastated the staff, and it devastated the leaders. It also devastated the passengers, and it cost them $41 million to recover from that storm. So how did they do it? They said, this is our recovery strategy. First of all, we're going to name the problem. We're going to call it out what it is, and we didn't predict this. They said, we had data, and we didn't use it. And the problem is our processes are too complex. So what they did was they said, we're going to start using prediction in a different way. We're going to see all the pieces together. We're not just going to look at New York's weather. We're going to look at the whole country's. We're not just going to look at where planes are taking off. We're going to look at where they land. And they started to look at all the data in a totally different way. They named something that they call IROPS, irregular operations. That's when something goes wrong. And they put a name on it. They said, we're going to name it because it will happen again. And we're going to call it something special, and we're going to train our employees to work in IROPS. We're going to cancel when we need to cancel. We're going to recover, and we're going to communicate. Because so many of the staff during that Valentine's Day storm said, we didn't know what was going on. We didn't have a good feel for it. And each person felt like they were working alone. So they decided to set up a communication system, a prediction system, and a recovery system. And then they said, we can't solve these problems at the top. We've got to go to the front line in order to solve these problems. They began to create meetings. They used value stream mapping and some quality improvement tools. They said that when they asked the staff, what do you do? The staff said it was bewildering complexity. And isn't that what many doctors and nurses are suffering through today? Bewildering complexity. Is the patient going to need an ICU bed or not? Do we have the supplies we need or not? All day long, it's managing around processes, some of them barely working and some of them working well. But this notion of leaders saying, we're going to go to the front line, and together we're going to map out the issues. We're going to do value stream mapping. They used pink and blue little sticky notes, and anything, pink and yellow, and anything that was yellow, they said is going to work well, and they put pinks all over the place. But the staff began to think about revising their processes totally. And the staff all started communicating. It's a joyous story to see how they revised their processes and what power they gave to their staff. They also said, we're going to build in empathy and mindfulness. They trained all of their staff in what the customers experience. They walked them through a cancellation. Every staff member had to try and board a plane in a wheelchair. They started to look at what it's like to fly with a baby on your lap for 2 hours. And they put all of their staff in the place of a customer to begin to help them to see what is it really like here. They created a customer bill of rights and managed handoffs in a new way. Now, Jetblue, just the day before I left to come here, was voted the #2 airline in the country. It's got a very strong brand. And the brand is strong for 3 things. It's strong for reliability, it's strong for customer satisfaction, and it's strong for low prices. It's a great experience and a very strong airline. The staff are back to loving their jobs. They say IROPS is just daily operations because when something goes wrong, everybody knows exactly how to resolve that problem. It's because of the value stream mapping and the lean methodologies and the changes that they made in the way they work and the way they work together that now if IROPS happens, it's not a problem at all. They know how to recover from it. This year, in 2012, we had a huge hurricane on the East Coast called Hurricane Sandy, and JetBlue sailed through it. What cost $41 million in 2007 with the new processes in place that they've got now was a very easy to manage process, and it only cost $500,000 to recover from that. So you can see how focusing at the high level on prediction and focusing on the frontline level at how do people work together can create reliability, resilience, and empathy. So your homework is, I want you to go back and sit in your next meeting and ask yourself, is the data that you're looking at old? Are you looking backward? Or are you looking forward? Are you using data to tell you what you did? Or are you using data to predict what you should do? And most people, most times that I'm sitting in leadership meetings around the world, they're looking back. And I'm saying that you need to see the future. You need to understand what might go wrong and develop that mindfulness and then build that resilience and that empathy into the frontline staff. So on this notion of empathy and mindfulness, as I mentioned, I think they did a fantastic job by having the staff walk through all the circumstances of what it's like to travel in an airline today. They looked at check-in, they looked at getting on with the wheelchair and all of these, and they taught them empathy by teaching their teams how to see. The question is, can we teach empathy? Can we teach it? And the answer is yes, and we need to do it. There are some research that's emerging now that's talking about empathy in 2 different ways. One way is clinical. And there's a physician, a wonderful physician, a psychiatrist and neurobiologist at Harvard, who's talking about the neuroscience of empathy. And she's studying the clinical changes in your body when physicians and patients are having interactions. The science is pretty amazing. When you watch the electrodes on a physician and a patient, and the patient asks a question, and the physician doesn't be prepared to answer, what happens to the physician? And how do they either become empathetic or how do they move away from empathy? But there's also some research in Massachusetts that's emerging that is showing that we are actually taking empathy away from medical students and nursing students during their training. And the hypotheses that are emerging for further study are these. The first one is that when a student comes in, There's a sense of hierarchy, and there's a sense that they're put at the bottom of the hierarchy, which takes empathy away from the students. What we're watching in these studies is the deterioration of empathy. From the first year when they come in, these students are filled with passion and they really want to help. In the second year, it's a little bit less, and by the third year, they're at a low point in empathy because of these three things, I think. One is that they're at the lowest end of the hierarchy and they feel like they're in a powerless situation themselves. So how do we build a sense of powerfulness? How do we build a sense of capability that a student who sees something can fix it? That's, in my belief, what quality improvement is all about. The second one is for self-protection. And again, this happens because of all the things I talked about earlier. Busy schedules, lack of sleep. They're constantly being bombarded with social media and the like, that they find that they start selecting which patients they're going to be empathetic to. If a patient comes in with a surgical problem and they really just want to get the surgery done and go home, then they find that they reserve their empathy and they don't apply it in that circumstance. They apply it liberally if somebody's dying or if somebody's in a socially desperate situation. So they start to pass out the patients and put empathy where they think it most is needed. And then the third one is this hidden message. And the message that these students are telling us is that they hear that medicine is a business, that you shouldn't be empathetic, you should be efficient, and that there's somehow subtly they're getting a message that you need to make a choice between one or the other. I don't believe that that's true. And I'm so encouraged by the students here at the IHI Open School, because when I see them come together, they're creating a global support network. There are almost 140,000 students worldwide, and I believe that they're keeping the empathy up. But it means that we've really got to work, I think, on this idea of empathy. I want to tell you about a patient I met in Minnesota this year. I was interviewing her in front of a couple of hundred people, and it was an example, I think, of some of the challenges that we face. Now, Beth is in her middle 40s, and she knew that she was coming to this presentation because she was a member of the breast cancer support group. So I said to her up in the beginning, I said, Beth, tell me about yourself. And she immediately, because she was in this group of us, healthcare people, she said, I have breast cancer. And I was thinking when she said it, how sad that the first thing she would say is, I have cancer. But that's how she identified herself. She talked about her chemotherapy and her radiation therapy. And I said to her, do you have anything else you want to tell me? And she said, I've had severe osteoarthritis and I've had bilateral knee replacements. And she talked a little bit about her depression. And I said, Beth, tell me about your last doctor's visit. And she said, I walked into the room. She said, this is what it's always like. You walk into the doctor's office. The first thing they say is, get up on the scale. So she said, I'm a little bit overweight. And the first thing they do when you go to the doctor's is they put you on a scale. And the first number they write down is your weight. And when you go in to see the doctor, the first thing they look at is your weight. And he looks up and he kind of gives me the look. So I said, Beth, what do you wish the doctor would know about you? And she said, I wish that he would know that from the time I was a very young girl, from the time I was 5 until the time I was 12, I was sexually abused by a family member. She said, my whole teens and early 20s, I was addicted to alcohol and drugs. She said, I was deeply depressed, and I really never thought that I would live to be this long. She said, I wish that he would know that I've been clean now for almost 20 years, that I have a job I love and I'm good at and I'm recognized at, and I'm in a wonderful, loving relationship. She said, I wish he would know how much I've overcome. I wish he would say, look how strong you are. You've come through a horrible situation and you are resilient. You're thriving. You're at a wonderful place in your life, instead of saying, you're overweight. And so I ask you, how do we move from what's the matter, the clinical number, to what matters to Beth? Because Beth brings resources. She brings strength and resilience. And we either take it away or we add to it. And I'm asking you to see Beth, because it's so important that we understand all of Beth, not how much she weighs or not whether her breast cancer is in remission. We've got so many lessons to learn from Jetblue, from Beth, from getting out there and looking at the patients and figuring out what are the assets they bring. Learn here at the forum about how we build great processes, learn resilience, and learn empathy. And the only way we can get to the IHI triple aim is if we really begin to look at all of the pieces of the strength that our patients bring. I was recently on a panel in Washington, D.C., where patient engagement was labeled as the next blockbuster drug, and I completely believe that. I believe that the closer we get to working with patients, the better cure we're going to get, the better health we're going to get, the better care experiences we're going to have, think Jess or Bill, and we're going to drive down costs because we're going to be working with patients to take the best care of them. There's a great experiment going on in Massachusetts, in my home state, where they took the elderly who were pretty much homebound and they gave them iPads. And they said, we want to do FaceTime with you. And the clinicians said right away, these old people can't use FaceTime. You know, they don't use this kind of stuff. But the testing people gave them iPads, and the pharmacist said, I'll call you at 8 a.m. and we'll do FaceTime tomorrow and we'll look at your meds. Well, it's amazing what's happening. I mean, they get up, they get dressed, they put lipstick on, they're like all excited because this is a visit to them. And the computer rings and they open it up and there they are in FaceTime talking to their pharmacist. They lay out all of their medications. They lay out their pill boxes and they're filling it and they're talking about what's this med for, why are you taking that. But this kind of interaction, when we value the assets of a patient, can provide tremendous improvements in clinical outcomes at a much lower cost. This pharmacist doesn't have to leave his desk and he's seeing all these elderly patients. And the elderly are certainly engaged because they're socially having an interaction as well as a medical intervention. Do you know what this is? 5,000 hours? This is the number of waking hours in a year that a patient with a chronic disease is taking care of themselves. So you might see the patient twice a year for 15 minutes. There's 5,000 hours of them taking care of themselves. So how do we optimize that 5,000 hours? How do we begin to think about what it's really like for a patient with diabetes or chronic heart disease? As a matter of fact, I want you to close your eyes for a minute. I'm going to pretend that the next patient you're going to see in your office is, let's say, a young patient with diabetes, a young kid with diabetes. And you're going to see this patient. I want you to close your eyes for a minute and think about this visit that you're about to have. What are the attributes, what are the features of this visit that you're going to have with a young kid with diabetes? Okay, you have the visit in mind? Okay, I want to show you a young kid with diabetes, and I want you to see whether or not your visit is going to meet Trevor's needs.
Hi, I'm Trevor Torres. I have eczema, asthma, I suffer from sleep deprivation, I'm allergic to nuts, but the fun one is juvenile diabetes, or type 1 diabetes. I was diagnosed with diabetes probably like 2 years ago, and I used to describe myself as a professional diabetic, except the problem with that is I haven't figured out a way to get paid yet. So until I do that, I like to call myself a diabetes evangelist, because I would recommend type 1 diabetes to anyone, and I'll get to that in a second. Just to describe a little bit with my situation, I pretty much do everything on my own. I track my own blood sugar, give myself my own shots, calculate my meals and insulin, and I've pretty much memorized the carbohydrate content of like every food in my house just because of how much I use it. So it's kind of a fun party trick, like, oh, hey Trevor, how many carbs are in like this soda? And I'm like, it's 42 for one can. And I would definitely recommend diabetes to everyone for 2 reasons, mainly, although there's a lot. I'm not going to list them all. One, it's so much easier to be healthier if you are a type 1 diabetic, because you're already looking at all the nutrition facts on your foods anyway. So I think that a lot of the diet problems people have is just because they kind of unconsciously eat something bad. They're like, oh, they look at their day or whatever, and they're like, oops, I probably shouldn't have eaten like that many cupcakes or something. And another thing I really like about diabetes, I feel like it makes me more confident. It's like, and this might be a little irrational, but it's like any accomplishment I have, I feel like is that much cooler because I have diabetes. So I accomplished this thing, and I had diabetes at the same time. There's two main things. One, don't condescend. Especially for me, I don't really like that because I am one of the smarter patients, and so I guess I could have said stay out of my way, but that doesn't really help very much. When I was first diagnosed with diabetes, they were like, you can give yourself insulin in one of two ways. You can do it based on your blood sugar. If you have higher blood sugar, give yourself more insulin and so forth. Or you can do it based on what you're going to eat. If you're going to eat X amount, give yourself X amount of insulin. And I was just like, well, that doesn't make sense. Why don't I just come up with an algorithm that incorporates both variables? So again, that's probably a little atypical, but if they already have something figured out, you don't necessarily need to lower the level of your explanation down to what you perceive your patient's level to be. You can explain something, and then if your patient doesn't understand it, they can ask, for clarification. Now that may be just me, but I really hate it when I feel like I'm being talked down to, and that also might be my age. I know we kids are a little upstart about that. So it's like, another thing that I hate is never say poke. I'm going to poke you. Like, no, you're not going to poke me. You're going to stab me, okay? A poke is where you prod someone with your finger. A stab is where you insert a sharp metal object with the intent either to inject a foreign substance into the body or to draw blood by breaking the skin. Little rant there. Another thing that's important is to understand how your patient learns. And I don't have all the answers here, but I know that for me, I really like to know why something's being done. Like, if a doctor just says, you need to eat this way, you need to do this thing, take this treatment, anything. If they tell me to do something, they better tell me why I have to do it. Because, one, that way I know I actually should do it. Because people tell you to do things all the time. And if I did everything that I know I should do, I would not have, I don't have time to do that. Ain't nobody got time for that. But if my doctor says, you need to take this medication because this is what it's going to do scientifically in your body, this is what's going to happen if you don't do it, this is what's going to happen if you do, then I know exactly why I should, and then I'll be much more likely to do it. If somebody is like, if a doctor is complaining like, oh, my patient didn't do X, Y, and Z, and then you didn't tell them why, you just told them to do it, well, of course they didn't do it.
So did your visit meet Trevor's needs? I see a lot of nodding heads this way. So I show you the video to say, in so many cases, we underestimate our patients. We underestimate their family. Now, if you talk to Trevor's mother, Trissa, Trissa will say, yeah, he thinks he does it all, but I'm the one who has to make sure there's healthy food in the house. I order all the meds. I make sure that all the syringes are in the house. So it really is a family caregiving event. But together, I think they make a great pair to kind of get this patient to be as healthy as he can be. So I think we've got a lot of work to do here. Your homework here, I think, is to sit in on a patient visit and say, is it designed for Trevor or is it designed for Beth? Are we taking Beth's energy away or are we building on the assets of Trevor? Because I think those visits are going to be very different, and we've really got to do some design work here, I think, in general. So then lastly, I want to talk about thinking about outside the walls. So how do we go beyond the walls of healthcare? And I was 2 months ago in Malawi, and I brought 3 lessons home from Malawi that I think are amazing lessons for us in the United States, and perhaps would relate to you as well. The first one was I took this photo of this woman. I was in a clinic, and I was noticing that all the patients had they had papers, like this woman's had a little blue notebook in her hand. And when I asked her what that was, she said, "This is my family's medical record." And I asked her why she was carrying it. And she said, "Well, because nobody else has the whole record. Sometimes I see this person, sometimes I see that person." She said, "It makes most sense for me, the patient, to own the record." And I thought, wow, we need that in the United States desperately. I think we need that worldwide, that the patient and the family are the owners of the record, so that as they're navigating through very complex systems, everything about the medications, the treatments, the history, the goals, what matters to them is in the same place in the hands of the patient. I thought it was a brilliant lesson to learn. The second lesson I learned was how ubiquitous quality improvement is. And I hear lots of times when I'm here in Europe or in the United States, even in other countries, what I hear is we don't have enough time to do quality improvement. We don't have the tools. We don't have the data. We don't have the technology. I can tell you, everywhere I went in Malawi, there were run charts and control charts up on the wall with just flip chart paper. People were doing very sophisticated diagnostics on their processes and making improvements. So quality improvement doesn't need expensive interventions. It needs people to take the ownership, put up the flip chart paper, learn the methods, and begin to make the improvements. And then the third thing I learned was that the healthcare system alone is only a tiny piece of the intervention, that we really need to think about all the assets of the patient, the family, and the community. And so I went to a village meeting where there's people assigned in a task force, men and women assigned in each village to run task forces, and they come together regularly, and they keep lists, registries, so to speak, of all the women who are pregnant, all the children who are under 5 and are needing medical interventions. It's the whole community that comes together on behalf of the health of this patient who is standing up telling her story. But everybody's concerned about health. And when you see all of these people together, it's really quite a dramatic thing, because the health of the community, I think, has got a much greater chance of improving when everybody's looking out for each other. When we look beyond the walls of the intervention and look really at the walls of the community as being the assets that we've got to build on. And there's a wonderful project that's going on in Scotland now. It's called The Early Years. And IHI's got the great privilege of working with the Scottish government on this. The aim of this is huge. It's to create Scotland to be the healthiest country in the world in which to grow up. Now, you might debate that. You might want to think your country should be, and I'd welcome the challenge. Take it on. But I do think that it's an amazing collaborative. What I see there in Scotland is that they did a wonderful way of thinking about this strategically. They began, under the leadership of Derek Feely some years ago, to begin to look at safety in a hospital. It's easier to see because you can walk into an ICU and you can see all of the people that work there. Derek collaborated by getting all of the hospitals in the country together, and with IHI started building improvement capabilities. And what you see in Scotland was first in ICUs and then in operating rooms, in medications management, safety spreading across the entire system. So it was a deliberate leadership act to say we're going to get safer. Everybody's engaged. Nobody can opt out. We're going to learn improvement methods. We're going to learn reliable processes. We're going to learn resilience. And we're going to build on that and spread it. Everybody's in. As Scotland got safer and their mortality rates started to drop, Derek's ambitions changed. And he said, we can now take this kind of thinking to other areas, mental health, and now to early years. And with Harry Burns, the chief medical officer, beginning to think about these kids from conception to 5 years old. When you think about it, if we get these kids healthy at 5, we've bought 70 years of great health in the future. And if we don't attend to them, and we don't build resilience, and we don't build health, and we don't build good habits, then we've bought 70 years of bad health. So I so admire the vision and the tenacity of Scotland to say, we're going to get safer, we're going to expand that safety to other aspects of health in the healthcare system, and now we're going to launch a collaborative that involves many, many others way beyond the healthcare system. The collaborative launched just a few months ago, and almost 800 people in the room. They were police officers and school teachers and nutrition counselors and social workers, people who took care of young children, and the healthcare system. But together, I really believe that this collaborative has got the potential to produce incredible results for the children of Scotland. I'm really honored to give you a little surprise this morning, and that is to say that Derek Feely is going to join IHI as an executive vice president to help us to spread this kind of thinking, not only from Scotland here, but worldwide. So I hope you will help me to welcome Derek Feely to IHI. And finally, I want to ask you to see something in a new way. If you were starting a new job at the Cleveland Clinic in the United States, you would get an orientation that would help you to see. And part of this orientation is going to help you to understand what I mean by empathy. So now that you've learned a new way to see, I hope that you'll go back and do. As Robert Francis said, it's time for action. It's time to remember Jess and Bill and Trevor and Beth and go back and figure out, how do we see what they see and how do we help them? How do we use all the assets of the patients and families? Thank you very much for this morning, and enjoy the forum.